Saint David, Chair of the British Computer Society Faculty of Health and Care, Deputy Editor of British Medical Journal of Health and Care Informatics, and Conference Director of the MIE 2025. I hope he's going to accept all our papers from this sentence. Philip worked in NHS in various IT development and management roles for 15 years before joining the academia. And he's a fellow of British Computer Society, fellow of Higher Education Academy, fellow of Health Level 7, and board member of HL7 UK. He's also co-chair of the Computable Biomedical Knowledge, which is he co-chairs with the Chuck Friedman in University of Michigan. And he is quite involved in EMEA as well, International Medical Informatics Association, and he's also in an evaluation working group, and they produce quite a lot of papers in the framework of evaluation of health informatics systems. Philip, without any further ado, and he's going to give us a talk about what's wrong with the computational intelligence in healthcare. Thank you very much.
Thank you, Abdul. So thank you for the invitation to come and speak to you today. So I wanted to pose this as a question, what's wrong, implying that there is something wrong. So what I want to take you through is kind of the current perceptions around computational intelligence versus the reality, and also a slightly broader view of what we mean by intelligence and really why it's so important in healthcare. So when we think about kind of the headlines, we do get this sense that AI is the answer to everything. We see headlines like these: transforming healthcare, the impact on workforce and organizations. It's not science fiction, it is transforming healthcare. These, of course, come from two big consultancy companies who make lots of money by selling consultancy about using AI, so they're not exactly neutral commentators, but this is the image that they are portraying, along with other ones like the one at the bottom, talking about financial benefits of AI. So there is this sense that it's almost just like some magic trick, that we deploy AI and therefore everything suddenly becomes wonderful. So to put it another way, it's this wizardry. On the left-hand side, we have the computational intelligence, what in some sort of app or device or piece of software, and we somehow get better outcomes. And that's the sort of sense that is being portrayed, that there is this kind of magic going on. So what I want to talk about today is, first of all, well, yes, we do need more intelligent healthcare. Why do we need it? Just remind ourselves of that. But then, what is intelligence? And I just want to talk briefly about three kinds of intelligence, of which computational is one. And then try and draw specific attention to the role of knowledge and how knowledge and intelligence should be interacting in healthcare. And then come back to the question, what is wrong with current computational intelligence? And then a summary, and hopefully get some questions from you. Look forward to discussing. So if I say anything that's not clear, please tell me. If I use acronyms that I don't explain, please tell me. Otherwise, please hold your questions till the end and we can hopefully have some discussion. So first of all then, why do we need more intelligent healthcare? Well, I want to suggest 4 reasons. One is the 60-30-10 principle, which we'll cover in a moment. Secondly is the workforce crisis. Thirdly is the triple aim of healthcare improvement, which has now become the quintuple aim. And then fourthly, the sheer volume and velocity of data that we have to deal with in healthcare. So first of all, what is the 60-30-10 principle? Well, this comes from a paper by Geoffrey Braithwaite and colleagues in 2020, saying that on average, 60% of care is in line with evidence or consensus-based guidelines, 30% is some form of waste or low value, and 10% is harm, and that this challenge has persisted for 3 decades. So obviously this is a kind of a summary. It's a crude attempt to, not crude, but it's a kind of rough attempt to show figures that have persisted for a long time. And they're quite frightening figures, really, aren't they? To say that less than 2/3 of care is in line with evidence or consensus-based guidelines, and so 40% of it we shouldn't be doing. So that says we need more intelligence in healthcare to change this persistent problem. So secondly, in the workforce crisis, there just aren't enough clinicians in all of these specialties. This is from a paper in 2022 showing projections there, some improvement from projections made in 2013, but even now saying that there's 10 million fewer clinicians than there should be globally. And of course, looking at the map, the red and orange areas clearly show that developing countries have an even greater need, as we well know, compared to developed countries. And we think we're badly off in Britain or in North America or in Europe, but obviously developing countries have it far, far worse. So there just aren't enough. We have a workforce crisis. And then we've had, again, these long-term ambitions for improving quality in healthcare. We started off with the triple aim some years ago, the pyramid on the left-hand side, reducing per capita cost, improving population health, and improving the experience of care. And that's been broadly adopted as a good aim for all healthcare systems to aspire to. That's been added to over the years. It became the quadruple aim. It's now the quintuple aim, 5 targets. So we've added in improving clinician experience, and we've added in advancing health equity. So those are all noble ambitions that should be done. In fact, they're part of addressing the 60-30-10 challenge. So again, these require intelligence for how we do this. And then there's this sheer volume and velocity of data. This graph from a 2011 paper is talking about facts per decision. So if you look at the left-hand axis of the graph, it says sets of facts per decision. And it's showing an increase over the years, and this is based on projections of what was expected around genomic data. So it may not be really, it hasn't quite come true, but the principle of it is the amount of data that's available and the amount of data that has to be processed by a clinician in any particular complex decision making. And the point of it is, it has long exceeded human cognitive capacity. So if you look at the right-hand side, human cognitive capacity is highlighted there. That doesn't change, but the amount of data that has to be dealt with in decisions does still keep on increasing. Clearly, something has to be done about the intelligence that's needed to deal with the volume and velocity of data which our digital systems now produce. So I want to talk about 3 distinct kinds of intelligence that we need in healthcare. So firstly, the individual human. Secondly, system or organizational intelligence. And then thirdly, computational intelligence. So first of all, then, the reason for that is that healthcare is a service, and any service comprises people, process, and technology. So healthcare as a service depends upon people who have human intelligence, processes which reflect system intelligence, and technology which contains computational intelligence. So given that kind of breakdown into those 3 areas, what is intelligence? What is human intelligence? I'm not going to take you through that long list on the right-hand side, and this comes from a famous, in the field of psychology, a famous workshop that was held back in 1921, where all these famous psychologists of the day got together to decide, well, what is intelligence? What is the definition? So you'll see they all came up with slightly different ways of phrasing it, in very different ways sometimes. But there was an interesting summary of this in a more recent paper from 1997. And I've highlighted there the key phrases. So it involves abstract reasoning, mental representation, problem solving, decision making, ability to learn, and adaptation. And I think you'll see that some of those keywords recur as we go through when we look at system intelligence and even when we look at computational intelligence. So for example, the principle of adaptation very much comes into system intelligence, and mental representation, or in fact the lack of mental representation, comes up in computational intelligence. So let's think about a little bit more about human intelligence first of all. So this is from Hans Eysenck, who was a famous psychologist in the 70s and 80s, famous for IQ tests. Now, these days, IQ tests are often treated rather dismissively, although they're still widely used in industry. And they measure something. People say, well, are they just measuring ability to do IQ tests? Well, perhaps so, but it's still a dimension of intelligence. So this was Eysenck's diagram of the various factors in human intelligence. So starting from the left-hand side, what he called biological intelligence. So what we get from our genetics, what is our basic genetic potential? What about the current state of our biochemistry affecting how our intelligence performs or our physical condition overall? That's then linked to the thing we measure, the psychometric intelligence or IQ, which is very much affected by these outside events, cultural factors, upbringing, education, socioeconomic status, and so on, ultimately leading to what he called social intelligence, which has, again, all these other external factors affecting actual behavior. So we'll come back to that link between intelligence and behavior in a while. But firstly, just thinking about the most basic fact of biological intelligence, what we're born with, in other words, and what we what we have in our brain. Interestingly, a review very recently, 2022, said we still don't really understand how that works. We know that there are genetic mechanisms, there are physically parts of the brain which are involved, and mechanisms within the cortex and so on. But we can't actually give a mechanistic account of why person A and person B have different measured levels of intelligence. So how does it affect outcomes? Well, you may have come across this separation of data, information, knowledge, intelligence. It goes back to Ackoff many years ago. And what this diagram is attempting to show is the distinction between the raw data that we receive through our senses, how we structure that, how we make sense of it into information, how it becomes knowledge, if that is what it is, and then how we apply that knowledge. And so in this diagram, it's suggesting that intelligence, a bit like Eysenck's social intelligence, is what we actually do with that knowledge and how we apply it. However, to understand this more accurately, I just wanted to highlight there's actually a couple of mistakes in this diagram, and the references are given at the end, so you can have a look at it. There's the obvious mistake that they've said physical word. They've spelt it wrong. They mean world. But the more important mistake is that their dotted line is in the wrong place. They've said that data only exists in a mental model. Well, that's not true, is it? Data exists in the physical world, and so does information, and so does knowledge. You know, you can get a book out of a library, and that book contains knowledge that is in the physical world. It becomes your knowledge when you absorb it into your mental model. But actually their dotted line, I would suggest, should be up here rather than down here. And that's one of the things we want to think about, is how these things can exist both mentally and externally. And we'll come back to that thought. So what about actually? What really happens? Well, again, coming back to this fact that we can't explicitly say where intelligence comes from biologically, but we can say that there's an element of nature, there's an element of nurture. Where you draw the line and say which is the most predominant factor, people have different views on that, and I don't think there is a clear-cut answer, but they both do have an impact. That basic intelligence is then interacting with knowledge through education and reading. experience, which perhaps gives more like tacit knowledge when we learn how to do particular skills. That intelligence then goes through a whole series of other factors before implementing behavior, because we're not just intellectual robots, are we? We don't just think like a Vulcan. We don't just think like an android. All these other factors, which we'll come back to, are the kind of gap between intelligence and actual behavior. And again, we'll see parallels with organizations and parallels with computational intelligence. And we'll come back to those other factors. So what then is system intelligence? And when I say system, I don't mean computer system, I mean organizational system. That could be a micro system, like a small team. It could be a meso thing, like an institution. It could be a macro level system, like a national health system or regional health system. So given that definition, what is the system intelligence? Well, a definition of organizational intelligence is that it's a cycle of activities, sensing the environment, developing perceptions, generating meaning, which again is what we do as individuals. It's what individual humans do. Organizations do it too. And they also use memory of past experience and then turning that into action and then learning from action. So in many ways, the intelligence of an organization is very much like the intelligence cycle of an individual human. So what does that comprise? Well, there would be agreed basic facts, so scientific methods and knowledge, picture of a library there, which is embodied intelligence. There will be the goals, the values, the structures. They will be part of the foundation of any system. And then, as per the previous quote, there's organizational memory, which could be embodied in things like policies and procedures, lessons learned, reports on incidents where things have gone wrong. And then on a day-to-day basis, the routine operational intelligence. So that could be things like distributed cognition, where knowledge doesn't just exist in one brain, it exists among a team of people, and that knowledge is shared, whether it's between, let's say, a team on a ward, a team across a management team across a whole hospital, or indeed a more senior team managing something like a regional or national system. And then that's supported by things like performance dashboards, key performance indicators. That's all used to be part of this learning cycle, as that previous diagram indicated. A cycle where we go from data to analytics to deriving knowledge. And that is the definition, really, of a learning health system. So a learning health system is exactly those things. And this is Chuck Friedman's diagram of the discovery side on the left, the implementation side on the right. So for any particular health problem of interest, we first of all extract data, we analyze that data, and we derive some knowledge. We then seek to put that knowledge into practice, whether it's through a guideline, through an implementation study of some kind, and we see what the results are. We see what the actual performance is, whether that's performance of an individual patient, a group of patients, an individual clinician or group of clinicians, or even an overall organization. And then we extract fresh data from that performance, and the cycle continues. We derive new knowledge and we see what its impact is. So clearly that relates very much to computational intelligence, where we're deriving knowledge from data. But more broadly, this concept of artificial intelligence, which of course is everywhere now, goes back to 1956, that particular phrase, and in the concept, obviously, even earlier. But in the specific phrase artificial intelligence coined by John McCarthy, it's really about simulating human intelligence. That was the fundamental concept of it. As the quotation there says, it's about any aspect of learning or any other feature of intelligence is to simulate that. And obviously that's what technology has been doing increasingly in recent times. And that falls into kind of two broad families with different subsets. So it started on the left-hand side with rule-based systems, where we had things based on existing human knowledge that were very well explainable. Whereas now the emphasis is very much on the right-hand side, the machine learning, neural networks, deep learning type approaches, where it's very much driven by data, but it's difficult or sometimes impossible to explain the logic of any particular machine learning model. So we've got those two kind of poles of, or families of different kinds of computational intelligence to think about. And that's reflected in the history of artificial intelligence in healthcare. So sitting alongside that is the broader industry trend. So this is the latest Gartner hype cycle for emerging technologies. I have to say some of the words on that graph, I don't even know what they mean. I've never heard of some of them. But apparently, according to Gartner, they're out there and they're somewhere in the innovation cycle. Interestingly, that you see they've posted Gen AI as now on the downslope. It's now past its peak of inflated expectations and entering the trough of disillusionment. I think there's some truth in that, but I think a lot of people are still being taken in by it and still do think it's magic. So we'll see where that goes. The point really of just showing this is people are affected by the hype cycle. People believe the hype, particularly governments who don't really understand anything, and other people who just take in what the media says. They are affected by this hype. That's an unfortunate but unavoidable, I think, reality. So let's look at the trends in the medical literature. Well, this is a paper that Niels Peek and colleagues did a few years ago, based on the AI medicine conferences over a 20-year period. And if you look at the blue line here, that clearly dominated from the mid-80s, peaked in the mid-90s, and has subsequently declined quite a lot, well, that's knowledge engineering, traditional rule-based healthcare AI systems. Things like ontologies, the orange line, well, it sort of bubbled along and had a bit of an increase, but fairly flat line. Ditto with image processing, which is interesting because that's now obviously one of the things that people just assume AI does image processing better than clinicians, often based on very biased studies, we should say. But clearly it is an area where there has been good progress made. Whereas machine learning, data mining, that's seen considerable growth and is now, although it hasn't hit the peak of the mid-90s knowledge-based systems, is certainly seen a volume increase. And this finishes 10 years ago, so it's an out-of-date slide. And I'm sure if you updated this, you would see that blue line now reaching, or if not exceeding, the peak of the knowledge-based systems in the 1990s. But I just wanted to throw in here, thinking about that, the question of research waste. Now, there's a very famous paper from 2009 that introduced the concept of research waste. And it's actually saying there's some research that we shouldn't be doing. It's a waste of time, it's a waste of money, it's a waste of resources. And the phrasing they used is to say, well, if the questions can't be answered satisfactorily with existing evidence, that's the only basis for doing this new research. If we already know the answer, then we shouldn't be asking the question again. Or it could be that methodologically the study is just so weak as to not be worth doing. And their assertion was that 85% of all health research is waste, which, when that was published back in 2009, amounted to $170 billion a year. I mean, that is astonishing, isn't it? And even if they're wrong by 50%, it's still astonishing. And there's a more recent paper, it's a blog actually, there linked at the end, which is well worth reading, about the fact that this is still a serious issue. So that's a broad issue across the whole of medical research. What about machine learning? Well, I did a series of queries on PubMed, looking at the number of papers that had the mesh tag machine learning. So this isn't all machine learning papers, it's only the ones that have got the mesh tag attached to them by the librarians. over the period 2010 to 2024. And it's probably not surprising that there's been a hyperbolic increase but in that period, just in the last 5 years, 20 to 2024, there's been over 40,000 papers on machine learning published in PubMed. And even if it only took 3 months to do each of them, I'm sure it took longer than that, but even if it was only 3 months, that's over 10,000 person years of research effort have gone into producing those 40,000 papers. How many millions of dollars is that? And all of that machine learning has an environmental impact. We look at these gigantic data centers. Is it Google now who are wanting to have nuclear power stations for their data centers, as though it's a sort of God-given right to have nuclear power because you have to have machine learning at this scale. And so it's not just the research waste of the humans and the money that's funding them, it's also the environmental impact of all these data centers churning out carbon dioxide and all the other environmental impacts of indeed sourcing the raw materials that provide the computing power in the first place. So I would just pose the question, is that research waste? And I think you can guess what my answer would be. So I think that's something to ponder when we think about the massive rise of machine learning in healthcare AI. And I think it was well illustrated during the pandemic. This was a summary from MIT Technology Review. At the time this was written in July 2021, none of the AI models were of any help. And very often it's because people were asking silly questions that anyone who actually knew the context could have said, well, you're never going to find the answer to that using a machine learning model. Or some of them were just not questions that were worth asking in the first place. Having said that, in the end, there were 2 or 3 things that did prove useful. And you could argue maybe you needed a kind of survival of the fittest algorithm process to arrive at that. But still, there was an awful lot of machine learning for the sake of machine learning, rather than machine learning to actually address answerable questions. So moving back to our theme then, how does knowledge play into this picture? And I really want to highlight this relationship between knowledge and intelligence. So the classical definition of knowledge is justified true belief. So it's a fact and that you've got a good reason for believing. And I think it's undeniably true that in the world today, there is a huge amount of unjustified false beliefs. We have disinformation, we have misinformation, we have social media, which is full of all of these things. But when we get back to real knowledge, real justified true belief, that's what we're talking about here. It's a fact and you've got a good reason for believing it. But then there are, of course, different kinds of knowledge. So there's personal knowledge, and to illustrate that, we could say, I know that the cat wants more food. And how do I know that? Because the cat keeps meowing at me. Now, it may not need more food, but it wants more food, and it's telling me that it wants more food. Then there's procedural knowledge. I know how to feed the cat. I know how to put the dish down, how to open the sachet, how to put the food in. That is knowledge of a procedure, how to do something. And there's propositional knowledge, conceptual knowledge. I know that the cat is a mammal. So mammal is a made-up concept made up by humans. You never see a mammal in the wild. You only ever see an instance of a mammal subtype, a species. But I know conceptually that the cat is a mammal. It comes under that intellectual category. So that there are kinds of knowledge. Where is that knowledge? So this is coming back to the point about libraries. So Karl Popper talked about the 3 worlds of knowledge. And his world 3 is about the kind of stored knowledge. The fact that you can write knowledge in a book. That book can be in a library with lots of other books. It is knowledge. It may not at any point in time be in any human mind, but it is still knowledge in a book somewhere that can then be realized by somebody else reading it. Of course, most of the time we think about world 2, our own personal knowledge, which includes those things we spoke about earlier, tacit knowledge, through experience as opposed to formal knowledge through education and reading. But both of these two worlds in Popper's description are based on the actual reality, what's actually out there in the objective universe. But I think that fundamental point that knowledge exists not just in the human mind, but also in stored places such as books or computer software or other places is an important thing to remember, that knowledge isn't just something about human mental capacity. So moving on then to computational knowledge, and just briefly to run through again the distinction between some of those categories we looked at earlier. So yes, we do think about data, but really data is just a set of values. So there's a string of characters, numbers and symbols. Well, on its own, that doesn't mean anything just as data. However, it does become information when we detect or decode the meaning of that data. So in this case, that set of numbers happens to be a SNOMED CT code that means blood pressure. And you can then probably guess that the latter part of that string above is telling you the value of that blood pressure. That data has now acquired meaning, it therefore becomes information. And then there's knowledge, which is different, because whereas that specific piece of data, that specific piece of information was a blood pressure reading about a person, now we're talking about information that's generalizable across many cases. So we could say a piece of knowledge is something like high blood pressure is unhealthy. Well, that's pretty generalized, but it's still knowledge. It's a justified true belief. It becomes explicit knowledge if we're able to codify it in some way, if we're able to put a value on it, let's say. So if we say blood pressure greater than 140/90 is what we mean by high, that is our definition of high, and therefore unhealthy. And then it becomes computable knowledge if we're then able to execute it in a computer system of some kind. So that could be linked, let's say, to either a warning, or in this case, an internal process to say, well, let's look at some other risk factors. What do the other fields within that patient record tell us? Is there more than one risk factor that we need to be alerting about or triggering some kind of decision support about? So then that leads to this important distinction, as we had there, that not all knowledge is explicit, not all explicit knowledge is computable. So we do have to, we're not saying that every single piece of medical knowledge can become computable. Some of it can't at present and maybe never, but some can. So let's think about what we do with that knowledge that can be computable. So even then, for the things that are computable, there are different levels. So this is taken from the HR7 FIRE specification, and it's in turn, it's based from the Boxwala paper a few years back, which introduced this concept of the 4 levels of knowledge. So to kind of simplify that, level 1 is natural language, just narrative. Level 2, which they called semi-structured, I would summarize as an explicit conceptual model, because it talks about things like a flow diagram with explicit constructs in it, but it's also something that is readable by a subject matter expert. Level 3 is when it becomes structured, and specifically it's a standards-based logical and terminological model. And then finally we get to level 4, the actual executable implementation code, which runs in some sort of computer system. And there are so many examples of this. There are so many kinds of computable knowledge which exist right now in healthcare, from fairly obvious things like prescribing guidance to avoid drug-drug interactions or drug allergy interactions, rules that are linked to alerts, for example. So given a particular event, like a patient arriving in a clinic, a particular condition, such as the one we saw, a particular blood pressure value or some other test result coming in, leading to a particular action, whether that's an alert or reminder, or it could be triggering a next step in a pathway, such as a referral or a request for a further diagnostic test. And the same with all these other things, whether it's risk calculators, prioritizations, automation of processes, all of these things require knowledge. Some of them are kind of ways of representing knowledge, like ontologies or knowledge graphs. Some of them are very practical things like scheduling, or, as I've mentioned earlier, steps in a pathway, such as a referral guidance. But they all ultimately have to be based on knowledge. But currently, where we are with the existing industry software is what we've often described as a cottage industry. So like these pre-industrial revolution people working, producing things at home, selling garments, making products, all very nice. And there are people that still do that. But in terms of large scale, high precision, high trustworthiness kind of implementation that we need to see in global healthcare, where we are with clinical decision support right now is not in a very good place. There's so much duplication. Every single software supplier repeats the process of building their own executable version of some kind of human knowledge in a clinical practice guideline. Each time they do that, there are risks of getting it wrong or being inconsistent. Product A and product B interpret the knowledge differently. And of course, then there's the usability. Some of them are very poorly represented towards users. So in the UK, we've had agreement from NICE, the National Institute for Health and Care Excellence. They have agreed that the current way of doing things isn't good enough, and their way of doing things, of producing the guidelines in the first place, isn't good enough, as we shall see in a moment. And the movement which Chuck Friedman, and I was pleased to see Jeremy join the call just now, Jeremy Wyatt and I have been organising in the UK. What we're promoting through MCBK is libraries of computable knowledge. So it's mobilising this computable biomedical knowledge in such a way that it can be used at scale much more reliably. And clearly there's a lot involved in moving to that vision. So there's a number of things that are currently missing. So in the table on the right-hand side here, it's just showing the range of different ways that you can represent some of these things. So starting at the bottom, we've got basic concepts. So do we use SNOMED CT to identify something that's happened in the patient record? Do we use LOIC to identify a type of test that's been requested? Do we use, in the UK, we have a thing called DM&D, which is for our own local way of representing drug and device information, which is sort of linked to SNOMED CT, but not quite, and so on. The same when it comes to expressions in rules. There are different languages going right back to Arden syntax, which is still used in some places, through to things like Proforma, which came from Open Clinical. And then right the way up at the process pathway level, whole range of things from business process modeling notation down through some of these other things that have been experimented with over the years. So in other words, there is at present no lingua franca, there is no Esperanto for healthcare decision making. So rather than that, we actually have the Tower of Babel, where we've got lots of people speaking lots of languages and therefore not finishing the building. So this is a slide that Jeremy produced to try and illustrate the idea of interoperable knowledge, the MCBK vision. So we've got a range of different care settings here. We've got a patient self-monitoring at home or in a care home or in primary care or being served by some nurse or social monitoring service or even an app, a patient app. So at the moment, all those things exist. They're all separate services and they all have separate knowledge bases. They all have separate applications and separate patient records and separate ways of implementing those decision rules. What MCBK is proposing is that there should be a single set of underlying algorithms with a central library of algorithms and content. And so that then enables both a data flow and, more crucially, what we're saying here is a knowledge flow from this central library into each one of these services and the technology which they use to support their patient care processes. Another way of representing it from Chuck's slide here is going back to the learning health system cycle and saying that we need to move from the current situation where the systems incentivize publication, because that's how people's performance is measured, and we produce lots of lovely readable knowledge which nobody can ever keep up with, to a position where instead computable knowledge is the output, and we should be judging people on their computable knowledge output, not just their journal output, or instead of their journal output, because readable knowledge tends to work in about 15 years, whereas computable knowledge conceivably could be working in 15 weeks or 15 hours once we get things properly organized. So to give you a specific example of this is some work that we've done with NICE in the UK over the last few years. We did a project called the NICE Computable Implementation Guidance Project, NCIG. So back in 2022, I made a proposal to the NICE Content Advisory Board that we should just get on and try doing it and see what happens. And so we ran a series of these things called collaborathons to look at how we could represent guidelines in computable format. And that included looking at some of the technical standards that we mentioned earlier that have been used previously, as well as some more recent ones. So we brought together a group of clinicians, academics, and we had good industry involvement, I'm pleased to say. And we looked specifically at adult type 2 diabetes, which is NICE Guideline 28, and specifically within that, the blood sugar and medication management sections of the guideline. So we had a preparation period leading up to our first event in November 22. We then ran through a series of sprints leading up to our second event in March 2023. This is all reported in the paper that's cited in the references. So at these events, one of the most important things we did was to look at terminology. So within the human narrative guideline, what were the terms that we could immediately say, oh yes, well, we could say what SNOMED CT code that is, or what are the things which are ambiguous? What are the things that we don't know really what they mean because the wording is inconsistent? And then there are things that guideline developers tend not to think about, such as what are the user roles? Is this focused on primary care or secondary care? Is it focused on nurses or doctors or therapists or social workers? What's the patient involvement in the decision making? And then things like trigger events. So in software, you need to know what is the event that's going to trigger something to happen. What are the scenarios that we're dealing with? And then mentioning standards, we looked at CQL, which is one of the more recent HR7, or it has become an HR7 standard, as well as business process modeling. And I think crucially, one of the outputs of this, as may be visible from the photo there, is we developed an enthusiastic volunteer team. We had no reimbursement for this. This was purely voluntary work. But all those people from academia, industry, clinicians gave up their time because they could see this was important. And I think for what is in effect a piece of social engineering, that is really important. So we saw that there was more work needed to be done around a number of these areas listed here. We then carried on through the sprint work streams and did further works on the user stories, trigger events, the underlying information model, term definitions, as well as looking at the output format. We came up with discovering the World Health Organization Digital Adaptation Kit, or DAC as it's abbreviated. Now this isn't an executable model, it's what would be classed, I think, as level 2 or level 3 in Boxwala terms, but it's very structured. It's technology neutral, but it's a very structured representation of those 8 sections that you would expect to see in a piece of decision support. So, excuse me, that's actually led, and this is a nice slide, they have actually agreed a change now in their product strategy. So they are going to be enabling machine readable content through structured recommendations and frameworks, part of which is standardizing their wording. And they give an example here of where in one of their breast cancer guidelines, they use various different pieces of terminology. They're now going to standardize to make sure we have normative phraseology in the guidelines. And they're looking to use actions in language similar to the clinical practice guidelines on fire implementation guide. So they are recognizing the need to conform to international standards. And the way they phrase that is that everything will be in core components of the 5 things shown here: population, indication, contraindication, action, and outcome. And they've identified how that relates to computable components, which are needed for input, action, and result. Now, there is further work that still needs to be done. This is my slide, not theirs, by the way. How do we say, okay, those are the things they want to do? How does that map to the World Health Organization DAC? That's still to be resolved. And what we have had conversations about is what is a minimum viable DAC, because some of the things in those 8 sections are quite difficult to populate, and some of them could well be left to the industry or whoever implementer of the logic. So it's what's the minimum that NICE has to do for that structured recommendation to be useful. So how will this help outcomes? So NICE produce the knowledge that then interacts with the intelligence of the individual humans, of the system, the computational intelligence in the decision support software, and that then helps us have better behavior of clinicians and patients. Does it? Well, no, there's something missing here, isn't there? We need to go back to thinking about these other factors. So, of course, these other factors are what make this a wicked problem, not a linear problem. So, very well known, the social determinants of health. You know, we still have huge inequalities in terms of things like life expectancy. Just yesterday, I heard a doctor from Sheffield in the north of England describing the fact that within a single town, life expectancy of a child born today at one end of the town is 10 years more than somebody born at the other end of the town. We have things like behavioural factors, the psychological factors of motivation and so forth that go into why people do what they do. We have the fit between the individual, the task, and the technology, coming back to things like usability. And we have the whole massive range of different cognitive biases that affect how we use knowledge and how that actually turns into behaviour. So, in summary of what's wrong with computational intelligence, I would say it's not magic, even though people think it is. There is a real problem that there's a huge amount of data. We do need to help people deal with that large volume of data somehow, and better than we are currently, so as to address the 60-30-10 problem and the workforce crisis. We need to help people avoid being drawn into the shifting trends of technology and just doing what's fashionable. And we need to avoid research waste and just doing machine learning for the sake of doing machine learning. We need to recognise that the current industry state is very primitive. We do need to find a way to come up with a lingua franca so that we can share knowledge interoperably. And yes, we need to think about those other factors, that this isn't just an intellectual and technical problem. A footnote you may want to look at later, very interesting link I was just sent this morning. AI is dumber than you think. LLMs are not intelligent. They do not have an internal representation of the world. They are word guessing machines. And I think that's a very interesting thing to look at. So the answer, I would say, learning health systems, standards-based computable knowledge, healthy skepticism about AI in healthcare, and thinking about those behavioural factors beyond intelligence and beyond knowledge. Quick advert, Medical Informatics Europe is in Glasgow next year, and we have a very relevant theme, intelligent health systems, from technology to data and knowledge. It's not too late to submit a panel, a workshop, or a tutorial, and I hope to see you in Scotland next May. Here are some references, and I hope you have some questions. Thank you very much.